Hello friends, hope you're doing well. I'm Dr. Milind, your faculty for Pediatrics at FMG. So today in this video, what we are going to do is we are going to discuss the topics and the questions that recently appeared in FMG exam that happened in the month of July. And see, it is very important for us to discuss these questions and to know the topics which are the hot topics for this year's FMG exam. So we have a lot of, we have to see what questions came directly from our notes, what questions are based on our notes, and how to solve these questions. Because examiner, as I have said in my classes as well, that the experience of the examiner is going to be that the age of us is the experience of the examiner. So that is what we have to see. So we are going to discuss these topics one by one, and I'm sure you will find this video very useful. So first disclaimer that I want to give that all the topics in this video are only for discussion purposes, and any actual dissemble to any other form is totally coincidental. So let's start today's discussion without wasting a lot of time. So first, what we are going to do, so the format that I'm going to use is I'm going to give you the keywords. So these are based on the kind of topics or the question that had appeared in the exam. And what I'm going to tell you, see what happens in exam. So when you sit in front of the screen, when the question appears in front of you will see a lot of information. There will be a large question. Sometimes the question will be full 4 or 5 paragraphs. But your eyes, your brain should be focused on the important points. And these are the keywords which are going to give you the answer. So first question we are going to discuss and first topic that we are basically going to discuss. Actually, this topic was from the genetic syndromes. So we have a lot of genetic syndromes. So what can be asked from this area? So there was a question which contained keywords as mongoloid facies, prominent epicanthal folds, flat face, upslanting palpebral features, single transverse palmar crease, intellectual disability. So basically, this is they are trying to discuss and describe some phenotype like that, how this child looks like. So when you look at this database points toward Down syndrome, correct? So when you look at this database, this tells us that this is a genetic syndrome and mongoloid faces Down syndrome. So even, this is a very straight pointer when we discuss this question. Now, how should we prepare for exam? Again, genetic syndromes are very important for your exam. So what should we study? We should know the typical features, the pathognomic features. What does the word pathognomic means? This, if you see this feature, this is the answer. Like mongoloid faces Down syndrome. This single palmar crease that you have, we also call it a simian crease. So that is what should point toward the answer. So you had options like Down syndrome, Edwards syndrome, Patau syndrome, Fragile X syndrome. So if you know what are the pathognomic features, the answering will be very easy for you. Now in our classes, if you have attended our online or offline classes, you'll see we have already discussed. This is the screenshot from our notes which we had discussed offline and online as well. So you can see here the Down syndrome. You can see we had discussed in detail everything about the Down syndrome, about all the possibilities. What is the most common cause? So we know that meiotic non-junction is a major cause, and we commonly see it in elderly mothers, the mothers who get pregnant after the age of like 35, 40 years. They have more chances of having a baby with Down syndrome. So we discussed what all the features about the mongoloid slant, about the semen crease that we saw, about the low IQ, which was mental retardation. So everything basically we can see here that has been covered in our notes, and that will give you the idea about Down syndrome. So how the question can be framed. So if you are preparing for the December session FMG exam, what you will see that the karyotype might be asked. Like for example, we have trisomy 21 here. So question can repeat from the same topic, but it might be framed other way around. So that is why we should know everything about that. So definitely we have covered this in our notes. The other options that we had, I got feedback from one of the student that there was also a question asking karyotyping about Klinefelter. So this question also we have again discussed in our classes when we had discussed again online offline session. So again, I can show you the slide. So this is from our class notes. So they had asked basically about the karyotyping, that what is the karyotypic feature that you get. So that is 47XXY. Okay, so that is why you should prepare for topics and the surrounding information that you're going to get. See, whenever I'm teaching in the class, whenever I'm teaching you online or offline, one thing that I always stress upon is you have to read less, but you have to read it again and again. So you can see that the questions are coming from this information only. And when we discuss today's video, you'll see how useful these notes are if you revise them well. About Edwards syndrome, we know it's a trisomy 18. Okay, and Patau syndrome is trisomy 13. Okay, So we have these trisomies as well. Fragile X syndrome is another entity where we see it is actually associated with trinucleotide repeats. We will be discussing it in our class as well. So you should know at least the basic information. See, I'm not going to make this video longer and go into very which detail of it, because it is already we have we have covered a lot of information in the notes as well. So what we are going to do here is we are going to see how to approach a question and how information is going to help us. Okay. So genetic syndrome, again, you should note it down. Another important topic for your exam. Okay. Now we had the next question. The keywords were the 5-year-old child, dyspnea, repeated cyanotic episodes, digital clubbing, and chest X-ray. So let us see what can we make out of these options. Okay, so we have a 5-year-old child, child who is of a preschool age. Dyspnea means shortness of breath. So he is having difficulty in breathing. So what it can be, either a heart disease or a lung disease. Cyanosis. So there are cyanotic episodes which are appearing at 5 year, which are there at 5 year of age. Digital clubbing. This digital clubbing is a sign of what? It's a sign of chronic hypoxia. Okay, so this digital clubbing actually is a sign of chronic hypoxia, means this child has been deprived of oxygen for a very long time. So let's look at the options. The options were tricuspid atresia, transposition of great arteries, coarctation of aorta, and tetralogy of Fallot. So when we look at the options, we understand they are asking something from the congenital heart disease. Now we have to think that what is that presents. I mean, the child is at 5 year, but somehow he is able to live his daily life, but that is interrupted by the cyanotic episodes. So this is something that not causing distress immediately after birth. So that is one clue that we are getting. So let's look at the options. So how do you solve it? So you remember in our classes we spend a lot of time in making these boxes and this diagram. So let's make a heart chamber. See, whenever why I spend so much time on that, because whenever you get this question, it is very important that you first make a basic diagram. So you have a right atrium here, right ventricle here, left atrium here, and left ventricle here. Now, tricuspid valve is some valve that opens between right atrium and right ventricle. Okay, this is where the tricuspid valve going to open. Now, atresia means this is not properly developed. This door is closed. So, can blood enter right ventricle? No. Can blood go to the lungs via pulmonary artery? No. So, this will present at birth because the mixing between the right and left, there is no way that blood can go to the lungs for purification. Second option, you have transposition of the great arteries. Again, I discussed in the class as well. So what is transposition? As the name suggests, aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. So there's a transposition, and these two actually are the parallel circulations. Okay, these are parallel circulations. So again, if there is no ASD, there is no VSD, there is no PDA, child will not survive. And if there is a shunt, there is a bypass that is there, child is going to present at birth and child is going to be very sick. It's not like you get this child at 5 years of age. So that is why by age factor, these two are gone. Again, coarctation of aorta. What is coarctation of aorta? So when the aortic arch arises from the heart, so there is a narrowing of aortic arch. There is a constriction of aortic arch. So blood is not going to be travel to the lower limbs. So what history you will get? You will have absent distal limb pulse, like absent femoral pulse, absent popliteal pulse. So that is what a clinical sign will describe. Child will present in heart failure. In our notes we wrote in the 3rd to 4th week of life. So this question is actually from the congenital heart disease, and there are very crisp notes and very brief discussion we had already done when it comes to the congenital heart disease. So I'll just show you. So one of the sorry for this. So I'll just show you one slide from our class notes about the congenital heart disease, which we had discussed. So tetralogy of Fallot. So again, this discussion, the slides from our class notes. So there are 4 components of tetralogy of Fallot. I told you in the class as well. So there is one primary lesion that leads to development of other 3 lesions. Like you have pulmonary stenosis, which is actually a problem. So you have ventricular septal defect, you have a right ventricular hypertrophy, and you have overriding of aorta. Everything to diffuse right ventricular pressure, to decrease the output from right ventricle, so this blood can be taken to the left side of the heart. Now, what is happening here? At least there is some work that is going on. There is a ventricular septal defect. There is a mixing. Right and left can mix. So because of that, this child will have, again, I have mentioned here in the discussion, child will have cyanotic spells. and child will be normal in between. There will be clubbing because still there is a chronic hypoxia. The clubbing will be there because of the chronic hypoxia. But there are the repeated cyanotic spells that you see. So whenever you see these cyanotic spells, a child who is little bit grown older, think about TOF. And again, a few of the students, they told me that they had also shown the X-ray and typical shape they had seen. So that what we discussed in the class as well. So some people perceived it as a boot-shaped heart. So this heart looks like a boot shape. This is a boot-shaped heart. So even that was a giveaway for the question. So answer for this question was tetralogy of Fallot. Okay. So just look at the keywords. Again, ignore all the noise that is happening around. A lot of things that they are mentioned in the question. You have to just focus on the answer. Okay. Now let's move on to the next question. So we had next question. So we have a boy who is of age 8, has tremors, difficulty in speech. Then there is a raised bilirubin, hepatomegaly, cave ring. What is the best investigation? So they had asked what is the best investigation. So let's look at the keywords again. So 8, little bit late presentation because they are asking about some metabolic disease, right? Because there is a difficulty in speech, tremors. So neurological involvement is there. There is bilirubin, hepatomegaly. That means liver is involved, and cave ring, Kyle-Fisher ring. If you know it, if you know, even if you don't need other keywords as well. Just cave ring is enough. We all know that they are talking about Wilson's disease because liver is involved, your brain is involved as well. Okay. Now the question is, what is the best investigation for diagnosis? So this is from the metabolic diseases. So as we understand, we are talking about Wilson's disease. Wilson's disease is due to ATP7B gene mutation, right? And it is a disorder of copper metabolism that we understand. The body is not able to excrete copper. So there is excessive copper that is getting deposited inside your body. Now, how to diagnose this? How do you know that there is an excessive of copper? Now, there are some screening tests. Okay. Now, what are the screening tests? So screening test is basically, for example, you are walking down the road at night. Now, what you see a shadow. Now you call your friend and say, yeah, look at that shadow. What do you think it is? Somebody will say it's an animal. Somebody will say, no, it's look like a tree. So that is a screening test that you take a help of someone and try to see whether it is there or not. Now, what is the confirmatory test? You get a torch and put a light on it, and you know whether it's an animal or a tree. Similarly, screening test will tell you that okay, they will help you to narrow down. Okay, this looks like that. So your serum copper. So basically, we don't do a serum copper levels. We do serum ceruloplasmin, which is a carrier of copper. We check 24 urinary copper excretion, which are screening tests that will tell you that this child might have Wilson's disease. But what will tell you that okay, this is the Wilson disease? The best investigation is liver biopsy. Okay. Again, I'll just open the page from the notes that we had discussed. So again, defect in ATP7B, disorder of a copper transport. So this is again a screenshot from our notes. The involvement of what is giveaway again, involvement of liver, brain, liver, and the cave ring that they have given in the option. Okay. And again, what is the definitive? And again, I have like we mentioned in the notes as well. So what is the definitive or what is the best test is liver biopsy. So you take a piece of liver, and what will you find? You will find that copper content of liver is very high. It is more than 250 milligram per gram of weight of liver. Okay, so that is what you find. What other questions can be asked from this topic about treatment? So we have to induce first, means you have to flush out the copper. So there are two drugs, which are trientine and penicillamine, which we use for induction. And maintenance, we use zinc as a competitor. So zinc competes with your copper for absorption. Okay, so that can be asked question, as a question in your next exam. And about ceruloplasmin, so this option was not there, but remember, screening test, one of the screening tests that is used is ceruloplasmin, which is a carrier of copper. So if you have a lot of copper in your body, the your carrier will be depleted. So the ceruloplasmin levels go down. So this might be an option in your next exam as well. So just know this for your exam. Okay, again, very easy. So the answer was liver biopsy. What is the best test for this disease? Okay, again, I'm focusing on the key topics and the options that are asked in your exam. Okay, now let's talk about the next. Again, another question was there from the metabolic syndromes. So the keyword is you have an exclusively breastfed baby who has, so the baby is exclusively breastfed. Okay, you are not given anything apart from the breastfed. Now baby has become lethargic. There is a vomiting, hepatomegaly, cataract, and they're asking about enzyme deficiency. So if we look at these keywords and if we look at this topic, we understand this is from a metabolic syndrome. Now, what clue that gives us? See, in classes we talked what is metabolic syndrome. So if you have a substrate and you have a product, so if you do not have an enzyme in between, there is going to be a problem. So for exclusively breastfed baby, what is substrate? Milk. So there is something in the milk that child is not able to digest, and that something has turned into a toxic product that has led to hepatomegaly, cataract. So we understand this is something that is there in the milk, and here the thing that is there in the milk is lactose and galactose. Correct? So we understand that child is not able to digest the galactose. Okay, so here the topic that we are going to discuss is galactosemia. Okay, so the topic here in question is galactosemia. Okay, now we understand there are two types of galactosemia. One is classical, where we see all the problems. See, this galactose, the breastfed baby going to get this lot of galactose in his body, not able to process it. So it is going to convert into a galactylol, and it is going to cause all the problems. Okay, and the classical form, the classical type of galactosemia is caused by the deficiency of enzyme galactose 1-phosphatidyl transferase, which is responsible for all the clinical manifestations we are just going to see in the next slide. There is aldolase B. So aldolase B is also another exam. Whenever we talk about fructosemia, so we have a fructose 1,6-bisphosphatase enzyme. It is another name of that. Okay. You have galactokinase, which causes non-classical galactosemia. Okay. It causes non-classical galactosemia, very mild disease where you see cataract as a only manifestation. Only manifestation is cataract. Okay. And the last is phosphoruptokinase. So whenever we talk about Thyroid disease, one of the type of glycogen storage disease, so there you have this deficiency of phosphoruptokinase. Okay. So this is how the questions are asked. So just have a quick glance of galactosemia. So again, this is from our class notes. So we have this galactosemia. Again, I had written 3 Qs here because in the classes also I had told you that this is one of the hot topic and the question might appear in your exam, and it did. So the most common type is classical, where you see galactose 1-phosphatidyl transferase deficiency. And look at these findings. Again, we have seen in the questions. So there is a vomiting, there is cataract, and child has a liver involvement. Okay. So that is because of your galactose 1-phosphatidyl transferase enzyme, and you have a non-classical form where you have a galactokinase deficiency. So there are your phenylketonuria is there, your alkaptonuria is there. So just briefly, you should know at least enzymes and key clinical features. If you know these key clinical features, you will be able to answer the question. Okay. Again, I told you for exam what you have to do. All these enzymes very difficult to remember. Make a chart. Just write the enzyme name and the disease name, and stick it on the wall. Once in a 2 weeks, just have a glance of it. Just read it once. Trust me, by exam, you will learn it by heart without even realizing it. Okay. Now let's move on to the next question. So see, whenever an examiner is trying to set a paper, he is actually looking at two things. One is he's going to ask the some previous topics as well, and also one topic that is that is fresh, that is like we are seeing a lot of cases or like that. So recently COVID happened, so we saw a lot of questions on COVID in that year. Now there is one viral infection we are very commonly, very predominantly seen being we are seeing this in children, and this question was actually from that. So what were the keywords? So you had a fever, you had a sore throat, and there were vesicles which were on the hands, feet, and mouth. Okay. And there are similar cases among the classmates as well. So what this tells you? This tells you about some communicable disease. And we understand that in children, there are a lot of communicable disease, and especially viral diseases, which are very common. Okay. So basically, if you see, they're asking about a disease that involves hand, foot, and mouth. And that is actually the name of the disease. Okay. So hand, foot, and mouth disease. And trust me, nowadays we are seeing a lot of cases in children. This is a viral self-limiting disease, not a very severe disease, but we are seeing a lot of cases of this hand, foot, and mouth disease, which is also called as HFMD. Okay, so that is hand, foot, and mouth disease. So they just ask you that what are the causative agents. So see, indirectly we had discussed about herpes simplex virus and parvovirus B19 in our class. That parvovirus B19 causes your erythema infectiosum, and you have aplastic anemia, non-immune hydrospitalis. We have again wrote down this in the class. We know, but nowhere we mention about hand, foot, mouth disease. About HSV also we talked about the 6th disease. was there. We talked about, we understand that HSV encephalitis is there. We never talked about hand, foot, mouth disease in that part also. So by ruling out, also you can reach to the answer. But there are two causes which causes this hand, foot, and mouth disease. So one is your Coxsackie virus, and another is your enterovirus. Okay, so these two are the causative agents. So one of the option was Coxsackie virus. I did not get what was the fourth option from student, but Coxsackie option was there. So this is how this is how you have to think about the answer. Even if you don't know, even if maybe it is not there in some of your notes, you can still rule out other thing. And again, I say use your common sense. And sometimes when I wrote my exam, actually I used to read newspaper, and there was a question on beta quillin, and I actually read about it in newspaper because in the morning, because I was too tired of studying, so I just used to like check newspaper just for like 5-10 minutes as a time pass, and just because I'm bored studying. So this is also something that is in the news as well. So if you read, you never know what will help you. That is why I always see that it should be multicentric whenever you prepare. So I'll just show you some images, because this is again a very hot topic. So you might see. So what you see here? See hand, foot, and mouth. So this kind of this hemorrhagic kind of, this red kind of spots that you'll see. So this is kind of rash you see on the hand, foot, and mouth. So especially uh, this virus has a preference for infecting these three things commonly. So this is what HFMD looks like: hand, foot, and mouth disease. Okay, again caused by Coxsackie virus and enterovirus. Again, this is, I'll just write QQ, triple Q here, because I expect that again this question might appear again in your December session, and the option might be entero this time. So you never know. So you have to be prepared for this. Okay, let's move on to the next. So next question was actually from one of the guideline that we follow, and it's a long guideline that we have. And yes, there was some confusion about the options. Some had some confusion and discrepancy that what were the options. So let's discuss this. So you have a 4-month-old child, so it's an infant who has a respiratory rate of around 60 per minute. There is a chest indrawing, nasal flaring, and child is not feeding well. So what is likely diagnosis? So what we understand, see, it's a infant, okay? And if you remember from our classes, we had discussed for less than 2 months of child, if the respiratory rate is more than 60, for 2 month to 12 month, if it is more than 50, and for more than 12 month, if it is more than 40, we call it tachypnea. Tachypnea means rapid breathing. So what we understand here, that for 2 months to 12 months, less than 50 is a normal respiratory rate. So definitely there is a tachypnea. And there is a chest indrawing. So child is using accessory muscles. There is a nasal flaring. Nasal flaring means there is a dilatation of your nerves, so more air can go in. And child refused to feed because he is not feeling well. So what this tells you? This tells you that there is some compromise with the respiratory system. Now 4-month-old child. So let's see what we can rule out the option. So if I read this question, definitely it doesn't look like a URI. URI is upper respiratory tract infection. URI is upper respiratory tract infection. Now upper respiratory tract infection is your cough and cold, like normal, the running nose that you have. Definitely it doesn't look like that. This child looks sick. So URI is not that. The fourth option, asthma. See, asthma, what typical history you go get from asthma? It's a hypersensitivity disease, right? So you have a recurrent episodes of this cough, cyanosis, severe distress. There's a history of recurrent nebulization. There's a history of asthma in a family member. So these will be keywords that you should search there. So again, 4-month-old, and we label asthma after the age of usually 5 years. We don't label asthma before that. So that option I would definitely rule out. So now I know that it's a pneumonia, whether it's a normal pneumonia, just a pneumonia, or a severe pneumonia, because management depends on that. So what will help you here, even if you don't know the IMNCI guidelines, you understand. See, looking at the chest indrawing, not feeding, definitely it looks like a severe case. So if I have to put an answer here, I'll definitely put severe pneumonia. And now we have to, if discuss it in a more scientific way, then we have to go to the IMNCI guidelines. So these are guidelines set by Government of India to help the workers at primary health center and who are in the periphery to understand the gravity of the situation and what should be the treatment there, not for tertiary care center but for a peripheral centers. So for example, they define no pneumonia, pneumonia, and severe pneumonia. So no pneumonia is child who is having these symptoms of cough, coryza, cold, but there are no signs of pneumonia or very severe disease. Okay, so what we give, we just give soothing remedies, and we just advise mother to take care of the feeding, and we keep child in a follow-up of longer time, that is 5 days. So that is just a cough and cold. Now, what is pneumonia? So there is a fast breathing, and I told you that more than respiratory rate that is normal for that age will be defined as pneumonia. So there we give cotrimoxazole for 5 days, and we call child after 2 days because we understand child is more sick, can become severe pneumonia. So you have to closely monitor him. Okay. Now, what is severe pneumonia? So any general danger sign. So what are the danger signs that we can see? You can see here. So if child is not able to drink, breastfeed, child omits everything, child had any convulsion. Okay. So that means child is lethargic and child is having active seizure. So out of that, we saw in the question the child was not able to feed properly. So yes, that can be a danger sign. Apart from that, chest indrawing. See here, written chest indrawing or a stridor. Stridor means respiratory noise. When the child is breathing, you can hear the noise. So that is also a danger sign. And that is a sign of severe pneumonia. So what here we do, we give the first dose of cotrimoxazole and we refer him to the tertiary care center or a center where you have at least HDU, that is high dependency care, or you have a ICU available. So you have to send child there. Okay. So that is what they had actually asked here. So there are IMNCI guidelines about diarrhea, dehydration, and few common diseases that we see. Okay, so even if you don't know the guidelines, simple thing can help you to reach to the answer. Okay, I hope things are clear till now. So I'm going to just discuss the next question. The next question was about the viral illness. So what were the keywords? So you have a 3-month-old child and child has a pneumonia. They clearly gave you that the child has pneumonia. What is the causative agent? See, now during the early years of your life, like early 5 years, the physiology changes a lot. You're feeding for initial 6 months is just breastfeed. After that, you feed different things. You grow very rapidly. There are developmental milestones that you achieve. Now, similarly, mother who is, mother through her breast feeding, she will give the protective antibodies to the child. So these protective antibodies will save baby from lot of diseases after 9 months. Like we have a robust immunization program in India, like 6 weeks, 10 weeks, 14 weeks, we give immunization. From 9 weeks, we add another vaccines. So because of that, the causative agents are different at different age group because these all factors matters. So they had asked if child is 3 month old, what is the most common cause of pneumonia? So this is again a table from one of the standard books that we have for pediatrics, that is Nelson's. So that has given in early neonatal period, like when we talk about less than 3 weeks, group these are mainly gram-negative bacteria because we believe the source is can be a maternal, genital, or GI tract. So like your group B, Streptococcus, E. coli, other gram-negative bacilli are the leading cause of infection in a neonate. Between 3 weeks to 3 months, viral infection they take over. So you have RSV virus, you have rhinovirus, parainfluenza virus. So predominantly they are viral. Again, if you see between 4 months to 4 years, because we have major vaccinations available there. You don't have any vaccination against RSV. So that is why these are the common causes. I know the list is very long, but you can see that viral are the predominant cause between at least below 5 years that you have to see. And RSV is the leading cause of pneumonia. We had discussed RSV. We call it bronchiolitis as well. There is a monoclonal antibody called as palivizumab. So I'll just write the answer here. So the answer for this question is RSV. And there is a monoclonal antibody called as palivizumab. Again, we have discussed in our classes as well. So this antibody has been approved for the treatment of this RSV virus. This antibody goes and neutralizes the RSV virus. Okay. So this is the chart. This would help you to answer this question. Okay. So RSV is the most common cause of pneumonia in this age group. Also, Staph aureus is a cause of severe pneumonia. So the question says, what is the cause of severe pneumonia in this age group? You can see in this list, you will see other bacteria as well. But Staphylococcus aureus will cause a very severe pneumonia that will take child to the ICU. Also, one of the keyword that we remember is pneumatococcus. Pneumatococcus means air bubble. So in the lung, you will see lot of air bubbles. You'll see lot of air bubbles in the lung. That is also characteristic of Staph aureus. So this might appear as a question in your next exam. Okay. So that is what you should know from the point of pneumonia. Okay. Now let's move on to the next question. So this question was basically from the CNS part. So they had asked about a 6-month-old infant, and he had a brief episodes of spasms, which involved the neck muscles, trunk, and limbs. And these episodes appear in clusters. So there will be some episode for a while, and the child will be normal. So obviously you understand that these are seizure-like episodes. So you do EEG and you find hips arrhythmia. So what is the next step? So what is EEG? So EEG your electroencephalogram. So you try to record the electric activity of your brain. Whenever you have seizures, whenever you have convulsions, there is an alteration of this electrical activity. So this is the image. This is how a EEG is done. So you lie down calmly. You don't speak. You close your eyes, and these are the electrodes that are attached to your scalp, different part of your brain. Okay. So this is what it looks like. Okay. So basically, if you look at this slide, so they are asking about the spasm and hips arrhythmia. So these are actually giveaway to direct diagnosis. So hips arrhythmia is a very characteristic of your myoclonic spasm. So basically, they are talking about myoclonic spasms or myoclonic epilepsy that you are seeing here. Okay, and the characteristic is hips arrhythmia. I have just included the uh, EEG also after the slide. I don't think they will ask you EEG in your exam because that is too forward, and I don't expect that to happen. And in our classes, we had just briefly touched this topic. Again, we had talked. I had just written my. I remember my clonic spasm in the classes, and here you can see the drug of choice was ACTH. So drug of choice is your adenocorticotropin hormone that we use for this treatment for myoclonic spasm. And steroids are also commonly used drugs. In a lot of centers, we use steroid as a frontline treatment. But the drug of choice here is your ACTH. There is no option about steroids. The option that we see here is ACTH. You have other antileptic drugs as well, valproate, carbamazepine, and ethosuximide. So we had made this list. So you can see that ethosuximide is a drug of choice for your absence seizures. So absence seizures where you put a staring look. That child is looking at zero, not moving, not doing anything. That is an absence seizure. So ethosuximide is a drug that is a drug of choice for that. But that is not available in India. So India, valproate becomes a drug of choice for your absence seizures. Okay. And so that is how you can reach to the answer. Okay, so age group, the age of presentation, and there are again I will tell you, examiner will always try to help you in the exam, and there will be very see, the reason why I'm not putting all the question together, because we don't have to. This is what we have to develop. We have to develop this vision that you look at the keywords, because other options, other words might be there to deviate you from the correct answer. Okay, so I don't know you need it, but still I have put a EEG. So these are the electrode placement on the left side. What you see here, this list, this will tell you the level of electrode, like whether the occipital area, parietal area, and this chautic pattern that you see, this is what the hips arrhythmia looks like. But I really don't expect this to appear in your exam. Okay. Now, the next question is about the neonatology. So again, this question, see, there are some questions which there is, see, the portion is vast, medicine is vast. So there are some things that they ask, they challenge your common sense. They want to see whether you have worked in some hospital or not, or what you would do in a normal scenario. So the question says, there is a baby delivered through normal vaginal delivery at periphery. What not to be done immediately after birth? Now, what would I say here? So it's a vaginal delivery, and they are asking what you should not do. Let's look at the options. Breastfeeding within 1 hour of birth. Yeah, that I don't see a contraindication for that. In my question, there is no problem with the baby. Baby is not preterm. They have not talked about anything. So I think baby is good enough, and baby is okay for that. Okay for breastfeeding. So I would definitely do that. Putting the baby on mother's chest. Yeah, this is what we do, because if you want to breastfeed a baby, you have to put it on mother's chest. Also, we talked about kangaroo mother care. You want to keep baby warm. You have to keep it close to the mother. So this also looks a sensible option. Cleaning eyes with a sterile swab. See, earlier we used to think that we might need to, clean, like there was immediately after birth, we discontinued that practice. But cleaning eyes with a sterile swab without any medication, I don't see a harm, because baby is an amniotic fluid. There might be a mucus, there might be a blood that might harm baby's eyes. So I don't mind cleaning the eyes as well. Immediately bathing the baby. Okay, we haven't heard about this. What should we do? We should bathe or not? See, one of the problem that baby faces after the birth is hypothermia. that the baby is going to get cold very fast. Now, what actually gives me a little bit clue about the answer is periphery. So when they talk that the baby is delivered in periphery, periphery means not in a very good hospital, not in a proper setting, maybe in a PHC where you do not have a warmer care. So baby might get cold. So baby is actually covered in a protective covering. We call it vernix gaseosa. So this is actually a cream colored, what you see here is a cream colored substance that covers the baby. So when the baby is born, this actually prevents evaporation of the heat from the baby, and this prevents and saves baby from hypothermia. So this saves baby from hypothermia. So baby will not get cold. Okay. So for this scientific reason, I will not bathe the baby immediately, because if I bathe the baby immediately, this will wash out and this will predispose baby for the hypothermia. So if I have to choose one option out of this three, I will refrain from bathing baby immediately after birth. Okay. So for all this reason, this is the correct answer, and this is how I reach to the correct answer. Okay. Let's move on to the next question. So you have now 8-year-old child who is bedwetting at night around 3 to 4 times a week, and you have ruled out urinary tract infection. There are no neurological problems. What is the next step? So what do we understand here? 8-year child usually is dry by day by 2 years and dry by night around 3 years. So 8-year-old baby should not urinate in bed, right? That is a normal thing. So this does not look like a normal thing. So what can be the causes? If there is a urinary infection, that can actually leads to urgency and increase urgency and increase frequency of urination. We had ruled out UTI. There can be some problem with the neurological control of the bladder. So they have told you that, okay, neurological problem has also been ruled out. So this is actually enuresis. So how do you tackle it? How should you do it? So basically they are talking about the enuresis. Okay. Or we call it nocturnal enuresis. So it can either be primary, means since birth the child never achieved the bladder control, or it can be a secondary, means maybe initially the child had some bladder control, but now he has lost it. Now it can be anything. It can be primary. They have not mentioned about it, whether the child, when the symptoms started, but they're saying the child is having this problem. So remember, whenever we have nocturnal enuresis, first we rule out the urinary tract infection. We rule out the neurological problems, the local causes that can cause. Okay. Now, what is the next step? See, next step, whenever we want to solve a problem, initially we try to solve it by a simple treatment or a simple step. So here in this slide, I'm going to talk about a few steps that are used. Okay. So this is the order of treatment. So first thing what we do is we try to change the lifestyle. We try to implement the behavioral changes like optimization of the fluids. So we will tell child to take, suppose 100% fluids are being taken by the child, 40% fluids in the morning, 40% in the afternoon, and just 20% in the evening. So we restrict the fluid that the child takes in the evening. We avoid bladder irritants. So coffee, tea, your cold drinks, caffeinated products, or these are all your bladder irritants. So we ask the child to refrain from that after evening hours. Constipation is also precursor for your uh, nocturnal enuresis. So you try to treat that. You try to modify the diet of the child. You treat it with the some medications as well. And again, you give the charts and the night bed alarms. So again, this is the first step. So this is the first step that you do, behavioral changes. So what you are seeing here, that what we are trying to do here is we are doing behavioral changes. So here we are doing the behavioral changes, right? And alarm. So what are the bed alarms? So what you do, you set an alarm for 2 a.m. at night. You have to wake up the child. He'll go to washroom. Even if he doesn't feel like, he will have to pass urine. Okay. So by that, you avoid that. Okay. So this is what we do. This is the first treatment. If it fails, like you do lot of reinforcement and you follow up child for a few months, and after your follow-ups, there is no improvement, then you have to go for the drugs. Okay. So the first is behavioral plus alarm, followed by the drugs. The next thing that you are going to give is drugs. So the commonly used drug is desmopressin that we use, and then we look for the treatment. Okay, so imipramine is also used, but nowadays we don't use it. Desmopressin is the mainstay of the treatment. Okay, so that is why you should know it. You should know the correct path to the answer. Okay, so I hope you understand. And again, I'll write QQ because this is a very common topic and very commonly asked question in your exam. Okay. Now another question. So there was this question about recurrent pneumonia. So the keywords where there is a recurrent pneumonia. Recurrent means child is having this pneumonia again and again, again and again. There's a sinusitis. There's a diarrhea with fatty, bulky stools. So what is the diagnostic test? So see, there is a pneumonia, means lungs are involved. Sinusitis, sinuses are involved. Diarrhea, GI tract is involved. So it's a multicystic disease. So usually multicystic disease we see commonly in syndromes or the diseases which are systemic. Okay, so here we understand that child has something that has predisposed him to have a recurrent infections also and diarrhea also. Okay, so look at the options. So we have a sweat chloride test, lung biopsy, immunological assay, and stool microscopy. So stool microscopy will help you only to understand the problem that is there in the stool. And we can see there are fatty stools, so you don't have to go really and do microscopy. So here we are actually talking about the disease called as cystic fibrosis. Again, extensively we have discussed in our online as well offline classes. So this is that they are talking here about is cystic fibrosis. Okay, I'll just go to the next slide. So in classes we have discussed this cystic fibrosis in detail. So what is this disease? So it's a there is a failure of chloride transporter, and why this happened? Because of the CFTR gene mutation. So this gene encodes the chloride channel. So these chloride channels are not functioning properly. So your chloride gets accumulated in your body tissues. So there is a thickening of all the secretions. So wherever there are ducts, see when you have a lot of sweat, it's salty, right? Because of a lot of chloride and sodium that you have. So if you have a lot of chloride in your body, it is going to block all the ducts in your body. So wherever you have ducts, like in lungs, alveolar are like ducts. You have alveolar ducts, they are blocked. So you have bronchiectasis, pneumonia. Again, one of the keyword. If it goes and blocks the ducts in your genitourinary system, it will cause azoospermia that leads to infertility. In pancreas, it will affect the exocrine function of the pancreas. So you have lipases, amylases, which help you for digesting the food. Again, you have these oily fatty stools because you are not able to digest properly. So these all keywords diagnose, they points towards cystic fibrosis. And how do we diagnose? So the first thing that you do is a sweat chloride test. Okay, so sweat chloride test is it's a screening test. It's an initial test that we do, and usually the chloride levels are very high, more than 60 milliequivalent. Abnormal nasal potential difference, obsolete test, we do not use it anymore. Genetic study by confirming the CFTR mutation, that is a definitive. Okay, I have written in the red. So this is a definitive test by doing a genetic analysis. And bedside means if you are just seeing the child, you take a bowl of water, both of you dip your hands in the water and check for wrinkling. Like when you swim in an ocean for a very long time, you have a lot of wrinkling because of the salt water. So this wrinkling test is a bedside test. There's no a lot of like scientific basis behind it. It's not a very reliable test. It's just a I don't think it will ever appear even in an option in your exam, but you should know it's a bedside test. So the test that we are going to do here is a sweat chloride test. Okay, so here the answer for this question is sweat chloride test. Okay, they are talking about cystic fibrosis. Again, direct from our FMG notes. Now let's come to the next question. So you have a newborn of diabetic mother. So this is diabetic mother. Sorry, this is the one of the keyword is a diabetic mother. So mother has a diabetes. Now the blood glucose of the baby is 35 mg per deciliter. Again, this value is important at 24 hours of life. And the third important keyword is asymptomatic. Child does not have any symptoms. Okay. So the options are: first, give supervised breastfeed and recheck blood glucose after. Some of the students say it was 30 minutes, some say 1 hour. Second option was monitor baby. Don't do anything, just recheck the sugar after 30 minutes. Third option was just give IV glucose. The sugar is too low, and recheck blood glucose in 30 minutes. And the last is IV heart pump solution. So to reach to the answer for this question, we should go to the chart that we discussed in the class. Okay. So first about the infant of a diabetic mother. See, infant of a diabetic mother, what is the problem? See, mother has a diabetes. So sugar of mother is always high. So when the baby was in utero, the child was also hyperglycemic. So his pancreatic gland, there is a hyperplasia of that. So there was hyperinsulinemia. The insulin was very high in a child, the baby who is born to diabetic mother. Once the baby is born, you cut the umbilical cord. So the sugar supply is gone. Now child becomes hypoglycemic if you don't feed him properly. But insulin levels are very high. They are beyond what is required normally. So this child is at risk. The baby of diabetic mother. So baby of a diabetic mother. I'm sorry, I'll just write more clear. The baby of a diabetic mother. So if a diabetic mother is there, the baby will have hyperinsulinemia. Okay, hyperinsulinemia, and baby will be at risk of hypoglycemia. Okay, so baby is risk of hypoglycemia, and another problem that this baby also faces is hypocalcemia. These are the two major problems that you see in a baby born to diabetic mother. Now let's go to this slide chart that we see. So the levels are less than 45. Okay, so cutoff is less than 45. So remember here, it depends on symptomatic or asymptomatic. If less than 45 and the baby is symptomatic, you have to give intravenous dextrose. There is no other option. If the child is symptomatic, if the baby is symptomatic, and what can be the symptoms? The symptoms can be the baby is having these hypoglycemic seizures, or baby is extremely lethargic. The baby has become extremely lethargic or seizures. If the baby is symptomatic, you have to give IV glucose. There is no other option, whatever the levels are. I mean, less than 45, any level, 44 or 15, you have to give IV. Okay. Now the question says the baby is asymptomatic. Now, if the baby is asymptomatic, this is the management that you have to follow for asymptomatic baby. Okay, for the asymptomatic baby, this is the management we are going to follow. So what is the management we are going to follow? So if the level are more than 40, don't do anything. Continue breastfeeding and monitor the baby. If the level are 35 to 40, and in our question the levels are 35, which are actually in this category. So what we do, we give feeds and we check the blood sugar after 30 minutes. Okay, so you give feeds, observe feeds, supervise feeds, and check the blood sugar after 30 minutes, and then you monitor the baby hourly for a blood sugar, because if the child has become hypoglycemic once, he can become hypoglycemic again. Okay, so you have to be careful to that. And if it is less than 25, asymptomatic, you have to give IV glucose. Less than 125 asymptomatic, or less than 45 symptomatic, you have to give IV glucose in both the cases. Okay, so this chart is very simple chart we discuss in the classes as well, and this will help you to reach to the answer. So the answer for this question is give supervised breastfeed and check blood glucose after 1 hour. The last option, Heart-1 solution, they have written it just to mess with you. It has nothing to do with the glucose. This is just the electrolyte solution. So this solution is just the electrolyte solution. It is used in burns. In patient of burns, we use this Heart-1 solution. This is just the electrolyte. Whenever you have a severe diarrhea, or we have a like fluid loss or a burns, we use this Heart-1 solution. Sometimes what happens when you can't reach the answer, your brain usually picks up the fancy answer, and a lot of students might have done this mistake. Okay. So this question was easy. That is how you reach to the answer. Now there was another question, again a very simple question. So there was, what were the keywords? So you had a 2-week-old neonate who has a high direct bilirubin. So liver, high direct bilirubin, we understand there are two types of bilirubin, conjugated, unconjugated, direct or indirect. So indirect bilirubin is in the blood. It goes to the liver and converted into direct bilirubin. So this direct bilirubin goes into the bile duct, into your stools, which makes your stools yellow and your urine yellow. So what are they saying? That the color of the stool is clay. Clay means white. Clay means the stools are white or gray color, right? So why the stools are white? Why the child should have normal color of the stools is yellow? The child is having the white stools. That means this bile that is there. Direct means liver is functioning. Liver is normal. Indirect is converted into direct. But this bilirubin is not able to reach your intestines. So what is happening? There is a slight increase in STLT, means liver has started to get damaged as well. Now there are 4 options: Crigler-Najjar syndrome, unconjugated hyperbilirubinemia. So I don't think this would have been an option, because your question itself says direct bilirubin. So this cannot be the answer, correct? it is talking about unconjugated. Third is Gilbert, and the fourth is biliary atresia. Okay. So now let's try to answer this question. So we had discussed in medicine as well, and in pediatric also. We discussed few topics of medicine. So we have discussed this hyperbilirubinemia also. So if you have read either of these two slides, so this slide number 1 is actually from our medicine note, and the slide number 2 is actually from our pediatric notes. So if you remember either slides, you are saved. So first is about direct. So if you see what are the direct causes of direct hyperbilirubinemia, they are Rotor syndrome and Dubin-Johnson syndrome. Okay, and what are the causes of indirect hyperbilirubinemia? Means problem is with the liver. Liver is not able to convert indirect bilirubin into direct. So the options are Krieger-Nazar syndrome type 1 and type 2 and Gilbert syndrome. So Krieger-Nazar syndrome and Gilbert syndrome are actually types of indirect hyperbilirubinemia. Okay. So even if I know this slide, from this information, actually I can rule out Krieger-Nazar and Gilbert syndrome because these are the types of indirect bilirubinemia. My question asked direct. So by ruling out method, I can reach to the answer of biliary atresia, even if I don't know what is biliary atresia. So even if you have read the pediatric notes of our classes, which I had taught you in offline and offline both, so we know we have a atrophy of a biliary tree. So the problem is not with the liver, problem is with the ducts that takes bile to the intestine and urine. So what presents soon after birth? So you have to look at the presentation. So it has presented very early. The question says it presented very early. There is jaundice. There are pale or clay colored stools. This is what we had discussed in the class. Okay. And this is what a biliary atresia looks like. So remember, what are the keywords? It presents very early in the life. It presents very soon after birth. There is a jaundice. There is a liver failure. And again, key to the diagnosis, the stools are pale. They are white stools. Okay. And treatment is Kasai procedure. Might be asked. Remember, it's not like you can do the surgery at any time. If you do it within 8 weeks of life, it has the best prognosis. Okay. So that is how you reach to the diagnosis. So any information, this either of this information would have helped you to reach to the answer. Now let's move on to the next question. See, when I read this question for the first time, that is, I always say student, always read your question well. Even I was a little bit confused. So I read it that child licks or reads wall paint repeatedly, and then he's at risk of developing which of the following. So initially I thought, okay, they might be asking about the pica, but see, they're asking he's at risk of developing. So it's not like what he is going to be deficient in. See, there's a difference between deficiency and develop. Means what child will develop. They are asking the result. They are not asking the cause. If they ask you the child is at risk of deficiency of what, the answer would have been different. Risk of developing what means what would be the side effect that child going to develop. So obviously we don't know what zinc is going to do, and deficiency obviously not. So there is something in the pent that is risky for the child. So this question is like that, you know it or you don't know it. But if you look at the answers, it's very obvious that obviously we know that the workers at paint factory, they are also at a risk of lead poisoning, and they are exposed to the lead. So the answer is lead poisoning, and that is what you see in the children with that. Vitamin A is not there in the paint. He's not going to develop lead poisoning. So the answer is lead poisoning. And obviously, lead poisoning. Okay. So this is what actually happening. Okay, I'll repeat again. I think there was some connection issue. I'll just repeat what I have just said. So as I said that if there are condition in which child will start licking the wall paint, he'll start eating the soil. That is called as pica. Now pica is a result of iron deficiency. Now what will be the complication of pica? So if child starts eating wall paint, licking wall paint, it will lead to a lead poisoning. This is what they are asking. Okay? The answer is lead poisoning. Vitamin A toxicity, where you'll see in those, because vitamin A, A, D, E, K are lipid soluble. So your lipid soluble vitamins are always at the risk of having toxicity. Those pregnant female who takes retinoids for acne, their baby can have a teratogenic effect. And another is pseudotumor cerebri. Again, a toxicity of vitamin A. We discussed in our classes as well. Okay. And zinc deficiency can lead to acrodermatitis enteropathica. Again, we have discussed in the class. Again, let's not go into that. Otherwise, our video will be very long. I just want you to have a brief idea about each topic. That is the reason why I'm discussing this. One question from surprisingly, over the last few years, they have neglected the developmental, chapter. But now we had a question. So the developmental is 9 month old, and child is, and they had given you the milestones like he smiles, able to transfer objects from one hand to hand. Which other milestone present at this age? So they had just given you the age already, so 9 months. So they're asking ki which milestone among all these options is present there. So if you know the milestones, it will be very easy to answer. So child is able to creep well around and after 10 months of age. Okay. So we had discussed in our classes as well. So creeping and crawling, commandos crawl. So when your abdomen touches the uh, commandos crawl. So crawling is when your abdomen touches the ground. Creeps means when your abdomen is lifted off the ground. So that is creeping. So child is able to do creeping at 10 months. Okay. So creeps means abdomen is lifted above the ground. Mature pincer grasp is this. So I am able to hold a fine object using my two fingers. That is mature pincer grasp. So mature pincer grasp is at 12 months. Immature pincer grasp is 9 months. So if the answer, if one of the option was immature, that might have been the answer. Run steadily. So child is able to run steadily around 18 months. So again, and responds to name calling. So there is actually a range. So child, we believe that child is able to respond uh, to whatever audio clues you are giving, and usually the name that you are saying by 6 to 9 months. So they are if they are asking that what milestone is already present, yes, the answer is response to the name calling, because all other milestone they start to develop after 10 months of age. So 9 months, the best answer is respond to the name calling. Okay. So again, we have four spectrums: motor, gross motor, social, and language. I had in our notes, I have given you the brief list. All these milestones, at least ABC, are there in our notes, so you can roll out the option. So as I told you, there are 100 of milestones. You don't have to remember all. I have given you all the important milestones that are required in your notes. Okay. Now let's move on to the next question. So you have a 12-year-old child who has a short stature. Okay, so short stature basically is what we define it as: if you have a height for age, if it is less than -2 standard deviation, that if you take a height of a general population and if you plot it on a chart, so you find it that your height is less than -2 standard deviation. Okay, so that is what it is asking. The bone age is 10. So here we write chronological age. So what is chronological age? My date of birth by my age by date of birth. If I was born in the year of 2000, my age will be 25 years. So chronological age is 12 years and bone age is 10 years. See, bone age and chronological age, they go hand in hand. If you are 10-year-old, your bone age should be 10. If you are 12-year-old, your that should be also be there. Your bone age and chronological age should match. Here, what we are seeing, there is a delay. There is a delay in bone age. Okay. Second is they're talking about a segment. So we got I got some mixed reviews. Some students said it was somewhere 1.1 to 1 or 1:1. But we have studied in our why we need upper segment to lower segment ratio to know whether it's a proportionate short stature or disproportionate. So around 10 year of age, child's upper and lower at around 6 to 7 years, it becomes 1:1, and by 10-12 years, it reaches the adult. So it is not much delayed. So we can say it's a proportionate short stature, and child is otherwise healthy, and there are small testes as well. So basically 12-year-old child should have to start have some signs of puberty. So what we can see here, there is a delay of puberty as well. Okay, this small test is why they have mentioned, means the puberty has not achieved. It not might not be, we do not define it as a delayed puberty at this age, but what they want to say is the puberty has not achieved it at this age. So when we look at the option, familial short stature, constitutional delay in growth, achondroplasia, and growth hormone deficiency. So what helps us to the reach to the diagnosis? So just we have to see the chart again. I'll just go to the chart that we had discussed in the class, and there were two charts. One was about the proportionate short stature and disproportionate short stature. So whenever you have a upper segment to lower segment ratio maintain, means upper segment and lower segment has equally affected. Okay, when you have upper segment and lower segment equally affected, we have a proportionate short stature. So the options are chronic malnutrition, systemic disease, because in this condition your upper limb and lower limb is going to be affected equally. You have a familial short stature, you have a constitutional short stature. So these are the four options that you see. Achondroplasia, which is also one of the option in our question. So this causes usually disproportionate short stature. So I would rule out this option by this chart. Okay. So I am now stuck between familial short stature and constitutional short stature. So just the slide that we discussed in our class, difference between a constitutional short stature and familial short stature. Just two things will help you to reach to the answer. So the puberty is delayed and the bone age is delayed in constitutional short stature, and that helps you to differentiate between the familial short stature. So by these two simple charts, you can reach to the answer that it's a constitutional delay in growth and puberty. Okay, so it's a constitutional delay. They are talking about the bone age delay and the uh, pubertal delay as well. Okay, so that is, I think, something that is going to help you to reach the diagnosis. I also got some feedback from the students. So there was some question about the order of puberty in, I think, females. So I don't recall the exact question, but this is the order we have already discussed. So even if there was a question, you can answer from this small chart that we had given. So in males, the order of puberty is initially you have enlargement of testes, followed by penile enlargement, then growth spurt, and then facial and axillary hair will appear. Whereas in females, you have a thelarch, you have a pubarch, you have a growth spurt, and then you have a menarche. So this is the order that you follow in females. Okay, so I believe there was some question on that. So I think that is all. That all the questions that were there, and these are the topics which we had seen in this session of exam. So what does this teach? What this is going to teach us? See, as Chanakya said, that don't do all the mistakes and try to learn. They say learn from your own mistakes, but we not have so much of time to do mistakes and learn. You have to learn from others' mistakes. So whatever mistakes, suppose we have done in this exam, or if you are preparing, if you see the students telling you, okay, I have done this mistake, this recall should help you to address that. Okay. So what do I learn from this video? What do I learn from this, all the topics that we have discussed? First, keep it simple. So you must have seen the notes that we give you at FMG, and I have almost given explanation for all the questions. And most of these questions, more than 80-90% questions, are direct from your notes. They're directly taken from your, from your slides, from your notes. So keep it simple. You don't have to do any fancy things. You don't have to go and read 100 books and 100 things. You don't have to go here and there. Just stick to the notes that we have given. You have to read these notes again and again till your exam, and revision is the key. If you revise better, your silly mistakes are going to be less. And lastly, have faith in your faculty at FMGC. Whatever notes we are giving, my pediatrics notes are just 132 pages, including all, and you can see the number of questions that we got from these notes. So we are going to provide you a crisp but most productive notes that are available there, and we are always there for you till your exam. So guys, I hope this video helped you in a lot of way. I wish you all the best and take care.